Good evening, uh, respected chairpersons and moderators. Thank you very much for organizing this event. And today we are talking on cerebral AVMs. And uh, I'm Dr. Rajiv Jha. I'm a neurosurgeon from Kathmandu Beer Hospital. So I'm talking on AVM classification and anatomy. So cerebral AVM are the vascular abnormality, which is composed of a complex, tangled web of apparent arteries and draining veins linked by an abnormal dysplastic intervening capillary bed or no capillary bed. So cerebral AVMs are rare. Found in almost 0.1% of the population, and which is almost 1/10 of the incidence of the aneurysms. About 15% of AVMs remains asymptomatic. They are only seen in autopsy series, and the majority of these AVMs are seen supratantrial, about 90%. The rest, only less than 10% are seen in the posterior fossa. And these AVMs commonly occur as single lesions, and in about 8-9% in the patients, they are multiple. And it has no gender preferences. So this is how an AVM looks like. We can appreciate from this picture that it has a four component. One is feeding artery, second is this nidus, third is draining veins, and fourth is neural parenchyma. So AVM are composed of a central vascular nidus, which is a conglomerate of arteries and veins. And there is no intervening capillary bed, and the feeding arteries drain directly into the draining veins by one or multiple fistula. These arteries lack of the normal muscularis layer, and so draining veins often appear very dilated, tough, due to the shunted high velocity arterial blood flow. Arterial feeders usually they might be single or multiple. They might be pile, perforating, or dural. Direct feeders supply as terminal branches, while indirect feeders supply to an end passes. And regarding this nidus is a compact tangle of dysplastic thin wall vessels of varied length connecting feeding arteries and draining veins. Nidus can be classified either as globular or conical in shape, and maybe compact or diffuse. And this classification of nidus is very important in deciding surgical approach also. There are multiple classification system for AVM, and this is the Lusenhoff Gennarelli anatomical grading is one of the oldest classification. This is the anatomical grading of supratentorial cerebral AVM described in 1977. According to the degree of surgical difficulty for total obliteration, which was graded into 1 to 4, this Lusenhoff Gennarelli grading of cerebral AVM is based upon the number of directly participating arteries for which there is standardized nomenclature. This is Spessler. Another grading is Spessler Martin grading system. This is an evolution in the management or definition or different approach for cerebral AVMs. And this was published in 1986 in Journal of Neurosurgery. According to this Spessler Martin grading system, it has three components. And one is size, another is location, and third one is nature of the, during deep venous drainage. And this Spessler Martin grading system, this predicts mortality, morbidity, and risk of surgery. This is very well accepted all over the world. Size has three grades, 0 to 3, given as 1, 3 to 6 centimeter 2, and more than 3 centimeters is 3. So size is defined as maximum diameter of the nidus in angiography. Another is location, non-eloquent or eloquent. This is still controversial, what is eloquency, but according to Spessler Martin, eloquent areas are sensory motor, language, visual, thalamus, hypothalamus, internal capsule, brainstem, cerebral perineal, and deep cerebral nuclei are the eloquent areas. Another is regarding third is deep venous drainage, whether it is absent zero, if it is present one. So AVM grade is a combination of all three parameters. And so Spessler Martin grade are further subdivided into three grades: low grade, high grade, and inoperable lesions. Grade 1, grade 2, and grade 3 are graded as low grade AVMs, grade 4 and 5 as a high grade, and grade 6 is taken as inoperable lesions. This is supplementary. This is from the supplementary Spessler Martin group. And there are disadvantages of Spessler Martin grading system, which are one is definition of eloquence. Number two is the lack of consideration for nidus compactness. And third is not useful for posterior fossa AVM and only applicable for surgical outcome in grade 3 homogeneity. And regarding risk of surgery, according to this study by Spessler and Martin and Heroes et al., and they have concluded that grade 1, Spessler Martin, grade 1 has 0% chances of minor deficit and major deficit, and 92 to 100% has favorable outcome. Grade 2, Spessler Martin, has 5% minor deficits, no major deficits, and favorable outcome in 95%. Grade 3, Spessler Martin, has 12% chance of minor deficit, 4% major deficit, 88% favorable outcome, while grade 4 has chance of 20% minor deficit, 7% major deficit, and 73% favorable outcome. Grade 5, 19% might have minor deficit, 12% major deficit, and 57% only will have favorable outcome. And in the 2010, again, there is modification of this Spessler Martin grading by Lawton Young, and Young, which is also known as Spessler Martin supplementary grading. So this is grading has been developed and validated to predict neurological outcome and refine patient selection. In the system, points in the following categories are added to the Spessler Martin grading. You see the three criteria which were added. One was patient's age, less than 20, 20 to 40, and more than 40 years. Another is compactness, whether the nidus is compact or not. And third is whether the aneurysm has bled or not. So based on this grading system, Kim et al. From their cohort multicenter study concluded that Spessler Martin supplementary grading system works better than the Spessler Martin grading for operability decisions, and cutoff value for operability is Spessler Martin supplementary scale of 6. If we count total, and in simple Spessler Martin, maximum is 5 and minimum is 1. In this supplementary, again, same point. I mean, minimum is 1 and the maximum is 5. So altogether, maximum is 10, minimum is 2. So cutoff point is 6. So supplementary, so Spessler Martin supplementary also gives better post-operative neurological outcome predictably than the Spessler Martin score. So patients with supplementary Spessler Martin grade less than 6 have acceptable low surgical risk, that is 0 to 24%, while those of grade more than 6 had higher surgical risk, that is 39 to 63%. Another classification is NATAF grading, and in this 4-point grading, uh, 5 angiographic parameters are used for the determinants of bleeding risk. Grade 1, A and B, grade 2, 3, and 4. So altogether 5. Grade 1A has, risk factor for bleeding. Grade 1 has with venous recruitment, and grade 2 without venous recruitment. Third is venous, grade 2 is venous stenosis. You see venous stenosis or venous reflux. Grade 3, deep venous drainage, and grade 4 is intra or juxtanidal aneurysm. So based on this classification, one study has shown that there is 13% of chances of hemorrhage in grade 1A, 38% in grade 1B, 48% in grade 3, and grade 4 more than 90%. Grade 5 not defined. Another classification is Vna classification, and this classification is helpful in choosing mode of treatment, especially for endovascular feasibility. It has similar uh, things like Spessler Martin grading, like from 0 to grade 1, grade 2, grade 3, and usually helpful in endovascular treatment. Yasar-Gill classification of cerebral AVM was based on ask of Mark concept, that is from 1938, where from the evolution of brain and its vascular system. And according to his grading system, he divided into two major classification. One is convexity, another is deep central. Convexity further subdivided as supra and infratentorial, while deep central as supra and infratentorial. The disadvantages of this Yasaragili classification is that feeding arteries did not correlate with location, so did not work for emboli. Another is Valvanis classification, which was published in 1996. They have grossly divided again as convexity or cortical AVM and deep or central AVM. Convexity or cortical AVM subdivided as sulcal AVM, gyral AVM, mixed or sulco-gyral AVM, diffuse cortical AVM, subcortical AVM. Deep or central AVM subdivided as subarachnoid AVM, parenchymal AVM, flexor or interventricular AVM, and mixed deep AVM. Another famous classification system for cerebral AVM was from C-chain. C-chain scale, which was published in 1986. This it is also another great elaboration of different factors, like there is some enhancement in the classification system. Like there are 4 components. One is size, another is location and depth, third is arterial blood supply, and fourth is venous drainage. See, different from Spessler Martin, that size, and they have 3 or 2 component, 3 or 2 subgradings, while it has 1 to 4 points in all these 4 compartments. So maximum is 16 point, and the size is like less than 2.5 to 2.5 to 5, 5 to 7.5, more than 7.5. And according to location depth, again 4. One is superficial and non-crucial area. Second is superficial and in functional area. Third is deep, not involving a vital structure. Fourth is deep, involving a vital structure, etc. And so modification in arterial blood supply and venous drainage. So based on this C-chain scale, finally they had, 7 grades. Grade one, between 1 to 2, and then 2, 2 to 3, 3, 3 to 4, and 5, altogether 5. So based on this grading system, they concluded that grade 1 and grade 2, 1 to 2 has 0% mortality, while grade 2 to 3 has chances of mortality 70%, grade 3 20%, grade 3 and 4 80%, grade 4, which is usually inoperable, has mortality not defined. This is so high. Another classification of AVM based on morphology of the AVM, where it is classified as subclassified as cryptic, that is absent on angiogram or surgery and pathology. Another is occult, that is absent on angiogram, surgery, which is seen only in pathological examination. According to the size of the AVM, they are classified as micro AVM, small AVM, moderate AVM, and large AVM. Micro AVM is the AVM which is less than a centimeter, small AVM less than 2.5 centimeter, moderate AVM 2.5 to 5 centimeter, and large AVM more than 5 centimeter. And now this another classification of aneurysm with cerebral AVM, that is intranidal aneurysmal AVM. So it has again 4 types. One is intranidal, second is distal flow related, third is proximal flow related, and fourth is unrelated. And based on this classification system, type 1 intranidal treatment modalities embolization, type 2, that is distal flow related, the treatment modalities, and the aneurysm and the parent artery were occluded with onyx at the same setting. Proximal flow related coiling for symptomatic and unrelated simply coiling or stent assisted coiling. Other classification system is best. I mean, they are. This is one of the institutional classification from Europe where there are 2 components. One is intention to treat score, and second is treatment risk score. So by combining these 2 scores, I mean, in intention to treat score, there are 2 components. One is patient feature, you see like age group and previous chances of previous hemorrhage or neurological deficit. Another is AVM characteristics. Another, so this combination of these 2 component and plus this treatment risk score, it is again based on the special Martin grading system. So they have made this brain AVM cumulative score, and if the point is between 1 to 10, they strongly recommend treatment. If it is 11 to 12, treatment offered with significant risk, and if it is more 13 to 17, treatment not recommended. Again, there is a 3-triad classification was made by, again, Spazzler and Francisco, who is published in 2010. And see, the authors proposed a 3-tier this classification for AVMs, and it is based on the original Spazzler Martin grading system, and reflects the treatment paradigm for these lesions. So they have categorized cerebral AVM in 3 groups. One is class A, another is class B, and another is class C. In class A, they have recommended this grade 1 and grade 2, Spazzler Martin grading, and class B is Spazzler Martin grade 3, while class C is combination of Spazzler Martin grade 4 and grade 5. The result showed that there is fewer significant differences in outcome between this grade 1 and grade 2 and grade 4 and grade 5. So they believe that, Spazzler Martin grade has 5 gradings and depends, and they believe that categorize this in only 3 class will make easy in selection and treatment modalities. And the other classification is by Buffalo. This is another, this is the proposed grading system is based on the observed risk with endovascular treatment of AVMs. So you see there are 5 grades, grade 1, grade 2, grade 3, grade 4, and grade 5. And they have classified as N1, and then D, and then E. N means it's a number of arterial pedicles. D means it's diameter of the arterial pedicles, and E is eloquence. So they concluded that smaller vessels are more prone to injury with catheterization. A greater number of arterial pedicles produces more potential risk, and eloquent location increases risk of neurological deficit. And they also concluded that the actual size of the AVM nidus and the venous drainage pattern are the less important during the embolization, which is of chief importance during surgical resection. And this is the latest classification of cerebral AVM based on the intranidal flow patterns by color-encoded 4D hybrid MRA. And they have subclassified in three groups. Type 1 is a homogeneous unidirectional flow, you see here. And this is the type 2 flow patterns in heterogeneous with two focal areas of either early or late in flow time points indicating a single branching of flow. That's type B. And the third type is which has flow pattern peaks and dips appearance so that the direction of the internodal flow cannot be appreciated. But when this 4D hybrid MRA compared with the DSA, simple DSA, there is a significant positive value of DSA as the venous drainage less than 2 millimeter were not picked up in this by this 4D hybrid MRA. So there are so many classifications, classification systems are made for cerebral AVMs, but different classification grading system can guide neurosurgeons in selecting AVM patients suitable for operation or in determining the best type of treatment to perform and in predicting difficulties as well as post-operative results. Thank you.